Good afternoon, dear students. Our today lecture about osteoarthritis and gout. First, about osteoarthritis. Osteoarthritis is a non-inflammatory degenerative condition of joints, but nowadays we check this disease as inflammatory disease and a local inflammation process present in the joints, but without inflammatory changes in the whole body, characterized by degeneration of articular cartilage and formation of new bone. The most common of articular disorder and first appear asymptomatically in the third or fourth decades and become universally by age 80. This picture shows the main localization of problems: hip joint, joints of feet, and fingers with Heberden and Bouchard nodules, knee joints also. And about predisposition factor, we have many factors which influence to the disease, and first of all, age, sex, ethnic characteristic, bone density also very important, and nutrition factors, genetics, obesity, previous joint injury, joint deformity, sports participation, muscle weakness, and of course, women are about twice as likely as men to develop osteoarthritis, and prevalence of osteoarthritis usually after 50 years old, more characteristic for men. Before 50 years old, more character for men, and after 50 years old, more character for women, because protection from estrogen decrease, and possibility of this disease also increase. And classification of osteoarthritis, primary and secondary. Primary without etiological factor, and secondary etiology is known. Once again, about the main risk factor. And risk factor for secondary osteoarthritis includes many problems, maybe secondary due to rheumatoid arthritis, spondylitis, gout, hemophilia, also with hemarthrosis, maybe cause of arthritis, after septic arthritis, after trauma, and others. And remember about structure of joint cartilage. This cartilage includes types 2 collagen, proteoglycan, hyaluronic acid, water, chondrocytes as the cells present, and this structure shows the organized molecule direction and presence of cells. In the middle we can see chondrocytes, and water molecule in young patient in big quantity, in elderly age decrease this quantity, and hyaluronic acid also add form of to the cartilage, and all of them responsible for normal structure and normal function. Hyaline cartilage is avascular, aneural, and alymphatic. Chondrocytes divided and increase the rates of both synthesis and degradative process. They have the longest cell cycle in the body, and we have knowledge about structure, and so we can prescribe some treatment for normalize the structure, and disease modified drugs about this type of treatment. Okay, and here a slide about some moments of pathogenesis and some problems with synthesis of bone tissue by osteoblast and some problems of collagen type 2 and protein ligand synthesis and also, we have metaplasia of the peripheral synovial cells, so we can see formation of osteochondrophytes, and it's additional bone, it's additional connective tissue when we check in the peripheral part of the joints, lateral part of joints usually. And body cyst also very often we can see in osteoarthritis, subchondral bone with bone cyst, and additional fluid into the joint, into bone space, and we can see this scheme in the picture, and we can see loss of cartilage in this joint, and this is a stage of pathology changes in histological examination, and also visible in X-ray sometimes, and also scheme of normal joint and joint with osteoarthritis. We can see inflammation of the synovial membrane, synovitis present, but it's not very obviously, and pain in the rest due to synovitis usually. And we have osteophytes, we have dilated cartilage, and additional bone cyst, and thickened joint, and finally we have deformity of joints, and fourth stage is not reversible, and patient needs for replacement. Here also scheme of changes in case of osteoarthritis. Also very interesting pictures about this in the right part, normal tissue, in the left part, joints with osteoarthritis. Here microscopy and normal articular cartilage with organized structure at the top, and in the bottom osteoarthritis with damage of cartilage and disorganization of connective tissue. And clinically, we have pain in the joints, and pain typically is worsened by activities, and in the rest, pain decrease. It's very important for differential diagnostics with inflammatory joint problems, and also we have some resistance when patient starts movement, and we have morning stiffness, but duration of morning stiffness not more than 30 minutes. Okay, and mechanism of symptoms, because mechanical stimulation of capsule of joints, and intraarticular pressure due to synovial hypertrophy, increased fluid production, and decreased joint compliance. And we have sometimes pain due to osteophytes, and also we have sometimes problems, very prolonged problems due to damage of nervous tissue and adaptive changes in the spinal cord and brain leading to persistent pain perception, and sometimes even prescribe antidepressants and others drugs for relief pain in psychiatric level. Okay, and about stiffness we discussed. Also, we have possibility to provide physical examination, and we should examine passive and active volume of movement in each damaged joint, and also check inflammatory changes around the joints, swelling, redness of the skin, and also provide differential diagnostics between the different type of problems with inflammatory changes in the joints. Okay. Also, we should exclude damage of soft tissue, bursitis, tendinitis, muscle spasm, and also should exclude inflammatory changes in the soft tissue. Okay, we also should examine patient, and if we can hear crepitation or additional sound when patient moves, it's also very important for the diagnosis. And joint deformities as a result of prolonged process when destruction of joints and absence of space between the joints, between cartilage, and presence of osteophytes in the late stage of the disease, we can also check. Also, this picture demonstrates the passive movement in the joint. Knee joint. Yes, we also can check the possibility for this movement. Key peripheral joints with Heberden and Bouchard nodules. Okay, and laboratory changes. Sometimes we can see mild leukocytosis in synovial fluid, but it's not pus, and without inflammatory changes in complete blood count usually. And radiological findings: narrowing of joint space, osteophytes, subchondral sclerosis, bone cyst, depends on stage. Stage 1, minimal changes. Stage 2, decreased joint space plus single osteophytes. Stage 3, moderate osteophytes formation, very visible. And stage 4, we have severe changes and deformity of joints. Here picture about X-ray changes in different step of osteoarthritis. And also we can see asymmetrical joint space narrowing and periarticular sclerosis, osteophytes formation, subchondral bone cyst in this X-ray. Osteoarthritis of hip joint also, approximately absent space between hip joints and pelvis, hip bone, and pelvis. Also, we can see osteophytes here. Deformity absent. It's a fourth stage of osteoarthritis of right hip joint. Key differential diagnostics should be between rheumatoid arthritis, gout, calcium pyrophosphate crystals deposition disease, septic arthritis, polymyalgia rheumatica, and others. And about treatment. First of all, non-pharmacological treatment, patient education, um, weight loss, physical exercises to improve muscles around the joints, physiotherapy in case of absence of severe inflammation, synovitis, if present, only corticosteroids, electrophoresis of corticosteroids possible in this situation, and of course, sometimes orthopedic device very useful for these patients, and joint protection should be proper footwear and some orthopedic device for fix fingers in the wrist. Also, we have symptomatic and disease-modified treatment. Symptomatic treatment includes analgesics, non-steroid anti-inflammatory drugs, opioids, and disease-modified treatment includes drugs like glucosamine sulfate, chondroitin sulfate, hyaluronic acid, and even specific metalloproteinase inhibitors, and growth factor and cytokines and inhibitors and diacerin, interleukin-1 inhibitors, intra-articular introduction of hyaluronic acid, corticosteroids like Kenalog, diprospan, and even chondrocyte stem cells transplantation. Also, we have topical treatment with corticosteroids, with specific non-steroid anti-inflammatory ointment, and we have choice if patient with severe osteoarthritis, and we understand that patient needs for replacement, we do it. If patient ask about symptomatic treatment, we prescribe for corticosteroids or opioids. In case of early stage, we may prescribe prophylactics and disease-modified treatment with chondroitin sulfate, glucosamine sulfate, hyaluronic acid in the second, third stage, also very useful. And between non-steroid anti-inflammatory drugs, we prefer COX-2 inhibitors if present some problems with gastric mucus, and prefer COX-1 inhibitors if problems with ischemic heart disease. And also, sometimes patient needs for antidepressant, antispasmodic drugs. Here we can see dosage of glucosamine sulfate, and you should learn more about regime of treatment and duration of treatment. Also about acetaminophen, we have attention because hepatotoxic effect present. Okay, and some information about COX-2 inhibitors, opioid analgesics, okay, and triamcinolone is more popular corticosteroids for intra-articular injection, but we should know this injection possible not more than twice a year. If we use very often, it leads to osteosclerosis and deformity of joints too. Some information about hyaluronic acid. Additional methods of treatment: joint lavage, arthroscopy. Sometimes patient needs for remove particles of cartilage through the joints, and because these particles may block intra-articular space, and surgery and even sometimes osteotomy but more often joint replacement. It's about proximal tibial osteotomy, but it's not very popular methods of treatment. Total knee replacement, we can see specific orthopedic device for this. And about gout. Gout, ancient disease, the king of disease and the disease of kings. And nowadays it's disease is not associated with rich patient. In the past, it was true because only expensive patients may eat more purine, more meat, wine, and other products. Nowadays, it's not so actually, and we have predisposition factor to this disease. Less of movement, obesity, intolerance in sugar, and also gout is predisposition factor to cardiovascular disorders. And this is very interesting description of first attack of gout and very severe level of pain, very severe redness, edema, and morning time usually for first attack. And yes, it's from the past description, but very actual up to nowadays. Key and stages of classical gout: asymptomatic hyperuricemia first, and acute intermittent gout, and advanced gout, chronic trophies gout. And cause start with big toe more often, but maybe atypical cause of disease, and onset atypical also is possible. Sometimes first will be knee joint or ankles or even elbows, fingers. From the skin, maybe more inflammatory changes than usual, and very similar to surgical disease, gangrene, and sometimes maybe onset looks like rheumatoid arthritis or polyarthritis, rheumatic fever arthritis, and sometimes high temperature maybe, but it's not very obviously. And in the complete blood count, we can see leukocytosis and elevated of speed of sedimentation of erythrocyte rate, and C-reactive protein also may be high. Okay, and then when hypertrophy, we have chronic form of gout, and atrophy usually associated with prolonged duration, more than 5th year usually, and the most popular place for trophy, ears, elbows, and wrist, but maybe different location of trophy and different size of trophy. Also, we can see pictures about this. And about diagnostics criteria, obviously we have crystal deposition in synovial fluid, and so if we have possibility to provide this examination with arthroscopy, with analysis of synovial fluid for crystal deposition, it's very actual for diagnosis. A serum level of uric acid also very important, and also we should examine patient about renal impairment and about stones in the kidney, and about presence of salts with uric acid. And of course, we have X-ray diagnostics, and also we can see chronic trophic gout in this picture, erosive bones, and different lesions due to deposition of tophi. Okay, and also about treatment in the short, first of all, symptomatic treatment for cure acute attack, non-steroid anti-inflammatory drugs, colchicine we use for this purpose, and about steroids. Sometimes in very active inflammation we prescribe steroids for short duration. And disease-modified treatment includes allopurinol, probiotide, anturan, sometimes others drug like fluoxetine, but most popular drug is allopurinol. And allopurinol we should prescribe after acute attack in chronic stage, and if more than 3 attacks, if tophi form, if we have renal impairment, urate nephrolithiasis, and nephropathy, obviously prescription of allopurinol, and we should prescribe specific diet with low quantity of urine. And also about regime of treatment, allopurinol usually started in a small dosage of 100 milligrams daily, and may add to the maximum dosage up to 800, and then decrease to the supportive dosage, maybe also achieve 100 milligrams. It's very individual and depends on course of disease. Okay, some information about probiotics. And this is in short way, but more information we should discuss in practical class.